a lot of times what we perceive as an injury isn't truly an injury. And I think that's where having a pain background helps me. You don't have to have tissue injury, meaning you don't have to have a torn skin, ligament, or muscle in order to have pain.
So important, because I think people, when they're in pain, obviously, like you said, they get guarded, they don't want to move.
Yeah.
And that's when you have things like arthritis set in.
Sure.
You know, it's not from movement.
Yeah.
It's from lack of movement.
Lack of movement, yeah, absolutely. I would much rather you engage in something you enjoy and be in pain, if you can tolerate it, than do nothing and still be in pain.
Kyphoplasty.
Oh yeah.
So tell everybody what it is,
Sure.
why somebody would need something like that, and what kind of results you see.
There's no downtime afterwards, there's no restrictions afterwards, there's not even a stitch, it's just a stab incision to insert the needle. I would say as long as you get good fill of the fractured vertebral body, they're gonna get instant pain relief.
Okay, so that's what I've heard. It's like almost a miracle procedure in a lot of ways, because you're immediately taking so much pressure off those nerves and off that injury.
Yeah, because it's just about the patient at the end of the day, you know.
Absolutely. Welcome to Medicine Uncensored. I'm here with Dr. Adam Abrahams. Dr. Abraham, can you tell us something that people don't know about pain, or something that they're getting wrong about pain?
Absolutely. A lot of times what we perceive as an injury isn't truly an injury. And I think that's where having a pain background helps me. Because at the end of the day, whether you actually, whether you broke your leg or your knee hurts or you had a cut, or, all that sensation, that uncomfortable sensation that we call pain, at the end of the day occurs at the level of the brain.
That's right.
Now, 90% of the time, we can relate that pain logically to an injury or what we call tissue damage. Mm-hmm. But what a lot of people don't understand, and this is where I try to kind of educate patients on, is that you don't have to have tissue injury, meaning you don't have to have a torn skin, ligament, or muscle in order to have pain.
Right.
But that doesn't mean your pain's not real. So it's not me discounting their pain, but it's educating them on the fact that you don't have to have tissue damage in order for you to feel pain. And that's actually a good thing, because that means that we're able to get you, that there's an opportunity to get you out of pain without having to physically change anything. A lot of the pain, like I said, educating them on the understanding that pain is a perception to some degree. Mm-hmm. And so a lot of what we're doing with physical therapy or modalities or ice or heat, it's not fixing anything, because you're not broken.
Right.
It's just about kind of recalibrating things.
Retraining it.
Yeah.
That's right.
If you're able to educate them into that, and it takes a little bit of buy-in, right? But if they come away with that understanding and they realize, okay, nothing's wrong with me, then all of a sudden they just feel way more relaxed. So there's so many times where patients will come in to see me and they'll be like, doc, they told me I can't lift anymore, I can't do anything. And I'm like, no. As long as you don't have some catastrophic injury, you are not going to make anything worse. If you have back pain and we look, you get an MRI, we get some x-rays and everything structurally is intact, you can do whatever you want.
Right.
Now, you may hurt, right? It may be painful for you to engage in an activity, but that's for you to figure out and us to kind of figure out together and help. And kind of a lot of the times just kind of getting patients from not being so guarded and allowing their body to kind of accept movement again
so important.
Is 80% of the battle.
So important, because I think people, when they're in pain, obviously, like you said, they get guarded, they don't want to move.
Yeah.
And that's when you have things like arthritis set in.
Sure.
It's not from movement.
Yeah.
It's from lack of movement.
Lack of movement, yeah, absolutely.
So it's super important to keep people moving and functional.
Yeah, I mean, and it perfectly is a spiel that I kind of give all the time is this pain stopping you from doing something? Well, it's no, I can do it. It just kind of hurts, but I can do it. Whether it be tennis or something that I said, I would much rather you engage in something you enjoy and be in pain, if you can tolerate it, than do nothing and still be in pain. Because at the end of the day, you're still in pain, so you might as well be in pain and doing some of the things you enjoy doing.
Yep.
Yes, I love the interventional aspect. I love doing injections and interventions and for sure. But plenty of people can do that. There's plenty of people. I'm not the best, I don't think I'm the best, needle driver there is.
Sure.
But what I try to offer patients, I think, is that other aspect, that education, that little bit more insight to help them feel a little bit more empowered.
That's super important. And you, because of your education and background, you are able to take a larger look at the whole scene.
Yeah, I would hope so. Yeah,
And
that's my
so
goal.
I think that that's super important.
Yeah.
So let's talk for a second about some of the interventions that you do.
Sure. Yeah.
One thing that I know that we touched on earlier before we started recording was kyphoplasty.
Oh yeah.
So tell everybody what it is,
Sure.
why somebody would need something like that, and what kind of results you see.
So this is like a very kind of specific procedure. So we'll have a little bit of background. So kyphoplasty, we'll talk about first what the indication for a kyphoplasty is. So kyphoplasty is done for patients what we call vertebral compression fractures, or VCFs. So a compression fracture is a break in one of your vertebrae, break in one of your spine bones, either it could be in your lumbar spine, your thoracic spine, or less likely in your cervical spine, mostly kind of thoracic and lumbar.
And it's in the actual,
it's the actual bone itself. And so they call it a compression fracture because what happens is, your vertebrae aren't just solid blocks. They're actually kind of spongy. If you were to cut a bone right down the middle, a vertebra right down the middle, and kind of right in half, you would see almost kind of like spider web kind of sponging. So usually due to some type of injury, either a fall, 90% of the time it's due to a fall, a ground level fall. And you'll end up getting a crack either in the top or the bottom part of the bone, and then it kind of collapses a little bit. So that's why they call them compression fractures. Now why do people get this? Because a normal person, or like a young person like you, like if you have a fall on the ground, you shouldn't break your back. So there's an underlying process that allowed this person to suffer another otherwise normal injury that's resulting in a fracture. And that's called usually osteoporosis.
Yep.
So weakening of the bones due to a kind of cascade of like different hormonal and metabolic factors. But to make it simple,
the body is sucking calcium from the bone.
So there's weakening of the bone due to hormonal changes, and a lot of times we see them in women, postmenopausal.
Yep.
This is like the primary, but men can get osteoporosis too and compression fractures. So this is the underlying process of what would result in a compression fracture. Now, once someone's had a fracture, so we kind of talked about like why these happen, right? Once a patient's had a fracture, it's first of all, they're in pain. And the pain is usually persistent, it's localized midline to the back of where that fracture is, and it's pretty relentless. In some cases, these will quote unquote heal on their own, but a lot of times they don't. And most of the time they don't actually. So, and that's where I come in. So if you were to have a compression fracture and see me, one, we would do an exam, get some imaging, definitely a set of x-rays, and definitely an MRI. And as long as we meet some other criteria, and mostly from insurance purposes, they want to see some type of conservative management was done, either with some type of bracing or pain medications or therapy, though I don't know what therapy helps a broken bone, but we're not going to go into I'm not going to go on a rant about insurances right now. So in any case, let's just assume that they met all the criteria, we're going to do this procedure.
Yeah.
So what this procedure is a x-ray guided needle procedure in which we make a tiny incision in the skin and we guide that needle actually into the bone, into the fractured vertebra. We then inflate a balloon to, one, reduce the fracture, meaning increase the height that's been collapsed as a result of the collapse, that's been reduced as a result of the collapse, increase that height, and then create a cavity. We then deflate that balloon and then inject cement, medical grade cement, through that needle under live visualization to fill that fracture line and stabilize that fractured vertebral body.
That's awesome.
And then that needle is then pulled out, and then the procedure is pretty much done. So it's sometimes it's done under local anesthetic. A lot of times it's done under light sedation. Rarely it's done under general anesthesia. I mean,
just unnecessary, probably.
Very, very unnecessary. Now, if it's done at a hospital, sometimes they'll do it for their own logistics sake, but most of the time it's just done under what we call MAC,
yeah.
or local anesthetic with sedation. The patient's then transferred to the recovery room, and then within an hour they're ready to go. There's no downtime afterwards. There's no restrictions afterwards, and the only thing you go home, there's not even a stitch. It's just a stab incision to insert the needle. I would say as long as you get good fill of the fractured vertebral body, they're going to get instant pain relief.
Okay, so that's what I've heard.
Yes.
And that it's like almost a miracle procedure in a lot of ways, because you're immediately taking so much pressure off those nerves and off that injury.
Yeah. I mean, just filling that fracture line, which is the main cause of the pain, with cement and stabilizing it, I mean, they get near instant relief. And it's probably one of the most satisfying things that I do.
I believe that.
And not only is it like beneficial from a pain standpoint, but I mean, there is thorough research involved that's been done that shows that not only that, it's life-saving. It's the number needed to treat to save one life is 14. And why is that? Is because when people do have compression fractures that don't heal, what ends up happening, and again, these are occurring in older people, they get decompensated, they get deconditioned, they get respiratory compromise.
Yep.
Because if you have a fractured thoracic vertebral body, you're not breathing because it hurts. Because every time you inspire, it's putting your ribs are expanding and it hurts. So they don't breathe as much. So they become shallow breathers. And then they get deconditioned and they go down this, what we call kind of this downward spiral, and they end up either catching a pneumonia, having respiratory compromise, pulmonary dysfunction, and they end up dying a lot of the times. If because of the pain that they're in, that they're not able to.
I'm sitting here realizing this. So my father, I have to send my father to you now. Yeah. He fell off a second-story balcony.
Wow.
While he was cooking about 2 years ago. 3 compression fractures.
Oh, wow.
He's a doctor.
Okay.
And knows best.
Of course.
And didn't do anything about it.
Wow.
And since then, there's been some pulmonary and there's been some issues.
Yeah.
He's probably got to check that out. Anyways, sorry, that's a side note, but
yeah,
I may need to send him your way. That's really, I never connected the dots on all that, but it makes sense because obviously your nerves and everything in the spine is connected to your organs all over the body.
Sure.
And it can affect everything.
Yeah. And the other aspect that I always tell patients too is, this is treating the fracture is going to help your pain, but it's not going to prevent future fractures. So if you're not going to treat the osteoporosis, you're doing the patient a disservice.
Yeah.
And that's what I always harp on my patients is we got to do both. We have to kind of fix this patch, right?
Yeah.
We got to reinforce the wall too. And so that's where making sure that the osteoporosis is managed and they get on some type of bone strengthening treatment to address the underlying weakening of the bones, that's what's going to also save their life. Because, a fractured vertebra by itself, likely won't kill you, but a fractured hip will. And so by strengthening the bones and getting them on proper treatment, you're preventing future fractures for, God forbid, another fall. Because falls happen,
It's so common, especially as people age and obviously with, nerve issues and things like that. I mean, this from PM&R. When somebody's starts to lose that function, they start to lose that balance.
Yeah.
Everything starts to go, and it only takes a couple falls, and you've got a broken hip.
And then you're kind of out. So, motion's the lotion. We want to keep people moving.
Yes.
So anything that we can do to do that,
Movement is the key.
Serves them well. So that's probably one of the more kind of, I would say, specialized, kind of advanced treatments that I offer. In terms of what we call the more, I would say, I don't want to call them routine, but more common, we'll say, are, epidural injections.
Sure.
So these are injections that we do in the spine, targeting inflamed nerves, either due to arthritis or herniated discs, causing pain either down the leg or down the arm. So we can do cervical injections in the neck or the low back. And then people have heard of, RFA or radiofrequency ablation. Mm-hmm. This is a different type of procedure in which we are essentially burning the nerve. For lack of a better term, I really haven't come up with one. I've used.
That's what it is. Yeah.
That's what it is. I mean, it's not using fire, but it's using heat.
It grows back, folks.
Yeah. So
usually
to different segments of arthritis in the neck or the back that's causing either purely neck pain or back pain. Mm-hmm. Again, great procedure.
Yep.
Can be repeated. Minimal to no risk. We do them in the office. They're outpatient, done under local anesthetic. And a lot of people do great with them.
Can you touch a little bit on what you guys do for stroke patients?
Sure.
I don't think most people know.
Yeah.
It is super important.
Yeah. I mean, depending on where in the brain you had your stroke, right, or where your injury was in your brain, you can have a variety of different issues. Yeah. So you can have weakness, you can have numbness, you can have cognitive issues. So some people just have pure motor dysfunction, meaning, for lack of a better term, they're like paralyzed, let's say, at half their body. Yep. And their mind's fine. It's more of a strength and rehab approach, but some people have cognitive issues, so trouble concentrating, memory, trouble swallowing. All these different things can occur in a stroke patient. So, when a post-stroke patient comes into inpatient rehab, what are the things that we're looking at? One, we're seeing what their baseline is. We're seeing what their deficits are. Where are they weak? What issues are they having? What's their swallowing status? Can they have intake?
And can I ask you something on that? So how do you measure that? Because I find that, one of the things that we've always tried to add in and use is objective finding.
Sure.
So are you guys using like computerized range of motion testing, or
for their strength and it's pure physical exam, manual motor testing on exam. So 1 out of 5, from 1 to 5 out of 5, and on manual motor testing. And so it's really the physical exam, sensation and checking their reflexes. So we're doing a thorough neurological exam that they're going to get while they're inpatient, and when they're first admitted. When it comes to their swallowing, obviously we rely on a lot of our therapists. So our speech, language, and pathologists. I mean, these are people who went to school for a dedicated specialization in speech language pathology. So that is working on swallowing and speech, right? The two main things that they focus on. When it comes to assessing their speech, we call them our SLPs, they're the ones who are addressing their swallowing status and staging them, and then transitioning them through the different levels of the different classes of like food category. So like bite size or mince or puree or what they're able to swallow. And then we also do the live visualization of their swallowing to see, are they aspirating of their, are they safe to essentially, have intake by mouth, or God forbid, are they going to aspirate and get a pneumonia? So that's a lot of that's done inpatient, right? And then they also do the cognitive aspect of it. So there's, they'll get an hour and a half of cognitive therapy on top of their physical therapy to work on memory, concentration, reading, writing, whatever their deficits are. Some of them will do even like melodic therapy. So like some patients, they'll get a certain kind of stroke where they can't verbalize things, but they can sing. So if they can talk in melody, they can actually have somewhat of a conversation. And so our therapists are trained in that. And so it's cool.
So cool. So that's got to be so rewarding. Oh, you get to see the patient just move along through the process.
100%.
I love that. So tell me a little bit about how your practice has evolved as a physician from PM&R into what you do now.
So PM&R is a neuro and musculoskeletal focused specialty. And so we kind of talked a little bit about the inpatient rehab, right? And then so the other kind of the other part of PM&R is the outpatient aspect. And PM&R outpatient, people with a background in PM&R, their outpatient life can really be whatever they want it to be. They can do sports medicine.
Yep.
They can do spasticity. So that's like where we treat patients with tight muscles, either due to previous stroke, multiple sclerosis, or cerebral palsy.
Yep.
And then we treat them with various medications, therapy, and Botox injections.
Yep.
So there are some PM&R people that just do spasticity when they get out into
You're
practice.
You're going to have to explain Botox injections.
Yeah.
I know why that makes sense.
So everyone's heard of Botox. Yeah. So really how it works is, in a very layman's term, is it's actually a medicalized toxin that we inject into the muscle to reduce the tightness, reduce its contraction. So
if you have contracted muscles from cerebral palsy or something like that.
Injecting a specific dilution of Botox will actually alleviate that. So that's one aspect you can do outpatient. Or you can do, like I said, like ortho sports. Some people were able to even do a little bit of kind of spine injections or interventional spine, as I call it. So kind of going through, and that was kind of where I geared towards. I love the outpatient aspect. I like the MSK. I like the interventional spine aspect of PM&R. And for me, it just made logical sense to round out kind of the breadth of my training with an anesthesia pain focused fellowship.
It's really a wide breadth of training.
Yeah.
I mean, it's very cool. It's heavily musculoskeletal focused.
Absolutely.
It's
kind of a jack of all trades, master of none type of approach. So
you can go into so many specialties with it.
Exactly.
And I think that's super useful.
It gave me a really good background, I think, in assessing patients from a functional standpoint that kind of serves well in a pain-focused kind of atmosphere. So
absolutely. So tell me a little bit about some of the procedures that you do now to help patients, and what conditions are you mostly seeing nowadays?
So I have kind of like a wide variety of patients. I kind of think of myself as a non-operative interventionalist, meaning I'll see anything from day 1 to surgery if needed for all musculoskeletal and spine conditions. So that was kind of like my background. But I will say my practice has kind of evolved into, I'd say maybe 75-80% spine, cervical, thoracic, and lumbar, and maybe 20-25% what I call MSK sports, musculoskeletal sports. So, shoulder injuries, knee injuries, hip injuries. Those are probably the 3 main big ones. And then we take care of some of the local sports teams in terms of like school coverage, and so working with some young athletes too.
That's awesome.
And then I get to see some of our own, exactly. And then so when it comes to, we'll kind of focus mostly on the spine aspect of it. We'll do every patient gets what I call like a multimodal approach. Yeah. So, yes, we do injections and interventions, but I never think of it as like a fix-all or a magic bullet. I'm very upfront with that when it comes to patients. We do things to help and kind of augment the therapy that should be going on in the background, because really rehab is like the cornerstone 100% of what's going on.
The problem I have found, and because we both work in situations where you've got multiple specialties.
Sure.
And I think that's number one, paramount in a practice these days, especially if your focus is musculoskeletal. Can you talk a little bit about the synergy that you get to experience from working with those specialties and the benefit that a patient would get from that?
Yeah, absolutely. Yeah, I'm like really fortunate to work in a setting where we have like specialists of the highest caliber in their fields all under one roof in the realm of orthopedics. So, whether it comes to spine surgeons, subspecialized hand surgeons.
You've got neuro, you've got ortho, you've got sports med guys.
Sports medicine, joint replacement subspecialists, spine, joint replacement, sports, hand, foot, and ankle are all kind of in one roof. And then a variety of different non-operative, so some more primary care, sports medicine, interventional spine like myself, or people like me who are kind of a mix of both. And then so when it comes, so that's just, the benefit is, it's intangible, honestly.
Yeah. Having it all under one roof.
Yeah, having it all under one roof and being able to, without needing a formal consult, let's say, if I see something that, a hand injury or a foot injury or 80%, 80-90% of the time I can pretty much figure out what I need to do, but I can always pick up the phone really quickly, have them take a look at the images themselves without having to formally do another consult and refer them to X, Y, and Z.
Send all
and
the
waste
records,
their time.
The whole thing.
So it's able to kind of just like expedite the process, get them into therapy, and get them where they need to go.
And I think that's one of the most important things, and one of the benefits from working with a group of physicians of different specialties is you can do something for the patient right away.
Absolutely. Yeah.
So tell me a little bit about what that looks like. What are some of the things that you can do?
Yeah, sure.
Right off the bat for a patient to help them that is suffering in pain?
Most of the time, so like let's say like a patient comes in with back and leg pain, right? This is like 80% of like our spine patients. When they come to see me, they're going to get a full assessment, interaction with myself, physical exam, and kind of hone in on where we think the symptoms are likely kind of stemming from, or how long it's been going on for. Is this more of an acute or a chronic issue or what have you? Well, everybody gets started on a strength and conditioning and rehab program. We're lucky enough that we have therapists kind of on site where I'm at, and I am able to talk directly with my therapists.
That's awesome.
So they get a little bit more of not just a one-on-one care with the patient, but I have direct communication with my therapist. So we've kind of built a kind of a workflow of what I expect of them and what I expect of the patients to see when they kind of go in for that.
That's great.
We get them in pretty quickly. And then there's always going to be a medication management component. So whether it be a variety of different muscle relaxants or steroids or anti-inflammatories, in rare cases, even opiates, for an example, if it's like an acute injury, but some type of medication management to kind of help them through that phase of their acute injury.
Well, it provides a rehab window.
Yeah,
and absolutely. I think it's super important. It gets overlooked. There's a time and place for medication, and it's if you've got somebody that's in acute pain and you think you're going to get them through a multiple visit rehab program, it's just not real.
It's not, exactly.
They're going to fall off, you're going to lose them, and then you didn't help the patient at the end of the day. So I think it's very important.
And then the big portion too is like educating the patient on like the injury process,
So Dr. Abraham, I wanted to talk a little bit about neuromodulation.
Sure, yeah.
And what are your thoughts on neuromodulation, spinal cord stimulator, PNS, DRG, things like that as alternatives or procedures in replacement of med management?
Yeah, sure. So neuromodulation, it's kind of exploded. So neuromodulation is essentially using medical devices to change our brain's perception of the painful impulses that we're feeling. And we can do that at different levels of the nervous system.
Okay, so right there, that was probably the best explanation in terms of what you just said at the very beginning, changing how the brain perceives pain.
Absolutely, yeah.
So it's not necessarily a fix, but it is a fix for the pain.
It is. I mean, at the end of the day, we just want pain relief, right? Correct. And all pain, as we said kind of in the beginning of this, is, well, all pains really occurs at the level of the brain, right? Yes. All painful stimuli, so you get a cut on your foot, that nerve gets an impulse, sends it up to your spinal cord, that goes up to your brain, and then you feel pain. So all pain really occurs at the brain. So, and that's where kind of neuromodulation kind of comes into play. And neuromodulation's kind of exploded. So initially, neuromodulation really only meant spinal cord stimulation, which is where most people have had some type of experience with it. So, there's and you kind of brought up really the three, right? So there's spinal cord stimulation, traditional spinal cord, that's kind of evolved into kind of its own. There's a secondary kind of more specific component to that, which is DRG, dorsal root ganglion stimulation. So that's where spinal cord stimulation, you're stimulating at the level of the spinal cord itself. Dorsal root ganglion, or DRG, is stimulating at a specific nerve root as it exits the spine. And then you have peripheral nerve stimulation, where you're actually targeting, for lack of a better, a peripheral nerve, meaning a nerve downstream from the brain and spinal cord. Correct. To target a specific area or coverage of your extremities, either your arm or your leg are most common, but other peripheral nerves as well. So it's so now neuromodulation is a big umbrella.
Absolutely.
And
really grown.
And figuring out is a candidate, or is a patient a candidate for neuromodulation is step one, and then what neuromodulation technique would you utilize? And that's really where kind of the physician kind of comes into play, because there's a big spectrum, and a lot of the times you can actually, certain conditions, there's not a wrong or right answer.
Yeah.
You can do peripheral nerve stimulation in some cases. You can do DRG in some cases. And I'll give you a good example is
a knee.
Knee, right? Yeah. So painful total knee, either due to arthritis or people who've had knee replacements already and they still have pain.
Yep.
What are you going to do with these patients? There's a big variety. And so what you do for the patient really varies on a couple of different things. And I'm sure you know some of this. One is what is clinically indicated, right? First and foremost. And let's say a patient is clinically indicated for all three. Let's say you could use all three neuromodulation techniques to address this knee pain. So what are you going to go to next? Well, then you would probably go to what you think is going to be the best suited in terms of that specific patient. Sometimes you may not want to do a spinal cord stimulator because some people just don't like anything having in their spine. It kind of freaks them out.
Well, it's a bit of a shotgun approach too.
Yeah, exactly. And then so it's not as targeted, but also some patients may not. Sometimes either due to comorbidities, or like if they're prone to infection, or if they have a high cardiac risk, or they probably won't do well with sedation for a procedure, you can maybe get by with something that you can do under local anesthetic, like a peripheral nerve stimulator, or like a temporary peripheral nerve stimulator. So there's companies that do permanent peripheral nerve stimulation or temporary peripheral nerve stimulation.
And so what he means by that, just so you know, is you're referring to where you've got sort of the magnet on the outside that you can. What
I'm referring to is, so there's different companies out there, and they have different products. But if I'm gonna let's say we're gonna do a peripheral nerve stimulator for the knee, that's that lead, which is essentially just an electrical wire, is implanted under the skin, and then it's connected to an external battery that's adheres to the skin, and it's temporary, meaning it's in there for 60 days. It performs its treatment, and then it's removed, and that's it.
Yep.
Some patients are different, depending on the condition and depending on the patient, we would opt for a permanent peripheral stimulator, meaning that same wire is implanted, but then the battery is permanently implanted.
Yep.
And so it's not a 60-day, it's a for life.
Yep.
And again, that's depending on the patient, depending on the condition and that conversation and what you think is best suited for. But as an example.
Absolutely. So can you speak to a little bit, a lot of these companies, and we've been to some of the same dinners, and we've talked to a lot of the same reps. And so there's different types of technology within neuromodulation. There's burst, there's closed loop.
Sure.
There's some of these. Can you speak to some of the science to what you've seen be effective for patients?
So I'll say this to make it simple. A lot of people do ask, there's Abbott, there's Medtronic, there's Nevro, there's Biotronic. All these different companies make spinal cord stimulators. Which one's the best? If one was the best, there would only be one company.
That's true.
Right? So the way I describe it to patients is either you're a responder or you're a non-responder to neuromodulation. So, I mean, we can get a little bit into the weeds about the different types of programming, but ultimately, if patients are gonna respond, in my experience, because I've used different systems, they're gonna respond to all the systems. Yeah. So really, people always ask me, well, why do you use X, Y, and Z? Honestly, it's more about, does this company support my patient? Are they gonna pick up the phone? Can I trust them? Are they gonna be responsive, and are they gonna answer all my patient's questions? And after, let's say somebody goes through the whole process, which we're kind of skipping over, of having a spinal cord stimulator, are they gonna be available to follow up with them? You know what I mean?
Absolutely.
So that is more important. All of that is more important than the system itself. Because if the system didn't work, they wouldn't get FDA approval, they wouldn't be a company, and so they all ultimately work.
Well, and I think it's important too, to your point on what works best for the patient. Some patients, I think it makes sense to where you've got a battery that some of these companies have batteries that never need to be replaced.
Yeah, absolutely.
Some of these companies have batteries that have to be replaced every few years.
Sure, yeah.
And it's like you've got to look at the age of the patient, the condition of the patient, and really decide based on that individual. And I think that's a really important component, as well as, like you said, probably the most important component is the service to the patient. When you're putting a device inside of somebody that's going to be there, you want to make sure that whatever company is involved, that they're going to follow up, that they're going to care.
Yeah, absolutely. And I want to make sure that they answer, because I know I'm going to follow my patient.
Right.
But I want to make sure that if I have an issue and I contact you, you're going to answer my phone, you're going to be in contact with me, you're going to take it seriously. And so ultimately that is really how I've come to decide who I use.
That's great.
When it comes to that. That's because it's just about the patient at the end of the day,
Absolutely. So what excites you most about pain management moving forward?
Oh man, it's the field is kind of exploding in a lot of ways. I don't know exactly how things are going to settle. There's a lot of different advanced therapies kind of coming out. Some of them are pending insurance approval. Are they going to be able to get adopted mainstream? Subject, to tell at this point, but I definitely think the field is expanding pretty rapidly, especially in neuromodulation and more advanced spine techniques. So, a procedure that's kind of come on the scene in the last, I think, probably 10 years, which is recent for medicine, just so everybody knows, is basivertebral nerve ablation, so BVNA. So this is a procedure, actually, let's talk about the indication for the procedure. So these are for patients with back pain due to what we call degenerative changes in the end plates of the spine.
So this is Intracept.
Exactly. So Intracept, we'll get into that. Yeah. So BVNA is the medical procedure. We are ablating, we are burning the basivertebral nerve, because that's the nerve that gives the sensation of the degenerated vertebral body. Now, we've learned that if you can, let me back up a bit. So Intracept, as you brought up, was the first and only company that developed a device to address this. So It's actually done in a very similar technique to what I described earlier with a kyphoplasty, in which we make a small incision, we guide an instrument into the vertebral body. However, rather than injecting cement to fill a fractured vertebral body, it's not a fractured vertebral body, it's in a vertebral body with arthritis. Rather than injecting cement, we deploy a probe through that same needle that then ablates and burns that nerve within the vertebral body, within the spine.
And that one doesn't come back.
And that one does not come back. No, that one does not come back. That's a one and done.
Yeah.
So Intracept was Intracept, the reason why it's referred to colloquially as the Intracept procedures, because they were the only company that had a device. Now, Stryker has also come out with their own device and system, and I believe even Medtronic is coming out with it. So you're going to hear kind of various names, but BVNA is the procedure, and this has been phenomenal for young, middle-aged to older patients with pure axial back pain who have degenerative changes in the end plates of their spine that will be referred to as modic changes on your MRI report if you've ever seen that. And for the pretty much forever, we couldn't do anything with these patients.
Yep.
And so I was fortunate. I actually just did one maybe 2 weeks ago. I did a 3-level BVNA, L3, L4, L5. And I mean, this is a guy that is active, fit. He's a physician himself. And just had this just relentless axial back pain. Axial meaning it's along the axis of the spine, just kind of right in the midline. And I mean, he had I'd say by a week out, I mean, his pain was reduced 80%. And
so he's done other ablations, I'm sure.
He's done facet ablations, the medial stuff. And but this was like really remarkable.
Wow.
And so, you asked me what's exciting to come down the pipeline. I hope to do more of these for the properly indicated patients and kind of see how they do, but it's been pretty rewarding so far.
It's a super exciting procedure.
Yeah.
I think the future is very bright. I think it'll be very interesting to see once all this data, especially from Neuromod. I mean, when you're installing a device in somebody and you're getting feedback from the patient, and I do believe that we will get to a point where we've got machine learning and big data.
Oh yeah.
That is really refining real-time settings for people and things like that. And I'm excited for that to move forward because honestly, Neuromod's not a new thing.
No.
It's been around over 20 years. I mean, it has evolved tremendously and the technology has gotten much better.
And we are seeing more something that's encouraging is that we're seeing finally some commercial insurance pick up coverage for peripheral nerve stimulation.
Yes.
Some of the Medicare plans, Advantage plans are getting coverage. So it's because it's really about patient access. You can have the best procedure in the world, but if it's not accessible to the patient, then it just stays on the shelf. So, I'm a really, all the different pain advocacy groups that are out there, different institutions that are making this possible for us. I mean, they're kind of have to thank them for opening up our way because otherwise we wouldn't be able to do some of this stuff. So,
absolutely.
Or even fight back against some of the stuff that they're trying to take away. A big thing last year was some of the Medicare proposals where they wanted to eliminate pain physicians, or really any physician really, they were going to eliminate accessibility to simple peripheral nerve blocks, which is like the cornerstone of our practice.
Right.
So a lot of different pain institutions came together and with different letters and things like that to kind of advocate against this proposal. So they were able to stop it, thankfully. So a lot of the stuff that I do for patients on a near day-to-day basis would have been eliminated had this kind of gone through. So yeah, encouraging. Also kind of have to kind of hold the line for the other things to make sure that patients don't lose access.
Insurance is always such a frustrating thing. I mean, it's just, to your point, patient access is everything.
Yeah.
And it's part of the reason why in the Midwest and in Ohio and Indiana, Kentucky, Virginia, all of that, West Virginia, why there's been such a problem, 10 years ago, 15 years ago, 20 years ago with the opioid epidemic.
Yeah, absolutely. Yeah.
It's because, listen, what other therapy could the patients access?
Yeah.
They couldn't access Neuromod. So what are the doctors going to do? They're going to do something for them.
Yeah.
They got to help the patient. So I think that's played a major role, and I'm absolutely trying to get in the gubernatorial candidate's ear that's incoming this year about it. Because we sit over here in Ohio, and I think Medicare reimbursements on average for a procedure that's interventional or minimally invasive is about 60% of Medicare rates. Mm-hmm. That's ridiculous. Yeah. Indiana, I think there's 7 other states that are at least 100%. They at least match Medicare rates.
Yeah.
Nobody is going to go perform a procedure even if the patient needs it, if they're going to lose a ton of money doing it. You can only give so many pro bono freebies out before you go out of business.
Yeah, and especially when it comes to a private practice setting, it's like it's the lifeblood of their institutions. I mean, this is what brings in to keep the lights on and pay our staff, so our staffs can have good jobs and live lives. So I mean, this is all,
and so that we can go out and help more patients and more patients. And it's like, you know, there's anyhow. So that's my
I mean, it's frustrating when there's certain procedures that used to be covered. I mean, certain procedures that used to be covered when I was just in training, that then were eliminated by the time I came out in practice, that I have to offer patients, and unfortunately they have to cash pay for things as an option.
I wanted to bring this up. I meant to bring it up earlier. Do you guys do much PRP over where you're at?
Yeah, plenty of PRP, yeah.
I have no idea why that's not covered.
Yeah, it's
great thing. It's been around for a long time at this point, you know?
Sure.
But I guess in medicine it's not that long, like you said, it's probably 10 years. A lot of procedures like that. Well, Doc, I really appreciate your time today.
Thanks for having me, seriously.
Thanks for coming in. I hope if you found this educational, please like it, share it, and send it to somebody that is suffering that could benefit.